Good morning, everybody. So thank you all for coming. And I really want to just explicitly call out the people that came from far away to give talks tonight to help create a community surrounding climate change and children's respiratory health. You're going to meet all these speakers through the course of the day. We really have truly an august group of people, and it's remarkable the level of selflessness that each of them exemplified to come here from far and relatively near, even though near being, say, Berkeley, it's not always so easy. Even actually getting across campus post-graduation was not so easy. So I'm grateful to everyone who's come today. And I hope that as the day progresses, we'll be able to build community and think about how we can begin to bring these two different groups, climate and health that's focused on children, even closer together. Today is also June 19th, and it's a very remarkably important day in the history of United States politics. And probably I think we can say that without much question, it was the day or the series of dates that really is when the American dream began to realize its egalitarian promise. Not that we've realized it, not that we're close, but we've begun to consider how we might approach it. And I think that actually started when we recognized the equality of all human beings who exist in the United States. We have a lot more to go, but we need to take a moment to recognize that. And I think one of the ways of doing that is to consider the words of Maya Angelou, who said, "You may shoot me with your words, you may cut me with your eyes. You may kill me with your hatefulness, but still, like air, I'll rise. But still, like air, I'll rise." More recently, one of the poet laureates of the US, who was, well, not a poet laureate, but she was really spoke at Barack Obama's inauguration and created great passion and ignited the flames of hope. This young woman, Amanda Gorman, wrote, "When day comes, we step out of the shade, aflame and unafraid. The new dawn blooms as we free it. For there is always light, if only we're brave enough to see it, if only we're brave enough to be it." And I think both of these poems are significant for what they represent to us as we consider the hope of change relative to what's happening in our environment and what we might do for children. And so today, in the next 8 or so hours, we're going to consider climate change and children's respiratory health. And I'm hopeful that what we'll do is test the hypotheses that progress occurs at the margins of disciplines previously considered to be distinct from one another. And in fact, this to me is the particular problem that we have to overcome, but if we are to make real progress. And that is, as Chris Eby taught me yesterday, that climate and health are considered so separate from one another at the levels of highest levels of administration, even at the NIH, when you look at what the budget is for climate change and health. And we need to somehow change that conversation. We also need to recognize that physicians, especially pediatricians, can engage and educate around climate change. We are among the most trusted professions across the United States. And among physicians, pediatricians are even more well trusted by survey than any other group of physicians. We need to leverage that trust in the hope of trying to educate people still more. And let's recognize and prove and demonstrate that climate change and health are inextricably bound. But why children's respiratory health? Is it the case that children are somehow a special class? Are they somehow differentially affected? Well, there's some reasons to consider that in the affirmative. First of all, children are born generally at term 36 or so weeks, and lung development, as you can see from this cartoon, continues on. And actually, most children are born with about 30 million gas exchanging units. That complexity and increase in gas exchange units continues on through the first 2 years of life at almost a logarithmic phase, such that when we are older folks, we see that there's about 3 to 500 million gas exchanging units. And that logarithmic increase in gas exchanging units happens during air breathing life when kids are vulnerable. And that means that any injury to a gas exchanging unit is a leveraged injury, such that we can cause a logarithmic amount of damage. If one lung unit is damaged, you're really harming the potential of 10 or dozens of lung gas exchanging units. And it is the case that gas exchange is absolutely critical, and the surface area for gas exchange increases at least through the first 2 decades of life. Some experts believe that it continues really into the 3rd and 4th decade of life, and that there's potential to recapitulate that developmental program such that in the face of injury, it can be reignited, and you might be able to reestablish new gas exchange units if the right conditions are present. But as you can see from this slide, there is this increase that exists at least through age 20, and that arc of that line continues to ascend. So we don't actually know when gas exchange units are no longer being formed. But it is also the case that it is a remarkable surface area that's present. And as you can see here, it's about 130 meters squared, which is the surface area of one side of a tennis court. If you lay down all the gas exchange units. So it's a wonderfully rich place for gas exchange to occur, but it's also a wonderfully rich place for there to be a lot of deposition of particulate matter if that's happening what you're inhaling. But why children? Why are children so differentially affected other than the fact that they're developing lungs? Well, we're fond of saying, us pediatricians, pulmonologists, that children actually have a greater respiratory rate per kilogram of body weight. And that actually is the case. You can see in this slide, which I took from an article in Lancet, that per cc of per kilogram, children are probably breathing about double the amount of air per minute than adults are. It's probably somewhere between 55 cc's per kilo in an adult versus about 100 cc's per kilo per minute in children. So you're breathing about more than twice as fast. You can look at these respiratory rates, and I based these calculations on what we anticipate to be the amount of breath that each person takes in with amount of cc's that they take in with each breath. And it's also the case that cardiac output, which is how you get pulmonary blood flow, increases, is significantly greater in neonates and in younger kids than in adults. And you can see in this slide taken from one of the fathers of cardiovascular medicine and pediatrics, Abe Rudolph, who was a giant and recently passed, was a chair of pediatrics for many years at UCSF. And in this monograph from Dr. Rudolph's, one of his books from the 1970s, he demonstrated pretty clearly that cardiac output is decreasing per kilogram of body weight with age, which is directly proportional to pulmonary blood flow. So as a result of that, not only is there going to be considerably more air brought in, not only is there going to be considerably more surface area for gas exchange per body weight, but there's also going to be more pulmonary blood flow. So any amount of gas and particulate matter that's taken in is more likely to be absorbed and more likely to get into the bloodstream to significantly augment the effects of any particulate matter that gets into the bloodstream. In addition to which, children are more vulnerable because they're lower to the ground. So particulate matter that is coming down from, be it fire, or be it from tailpipes, or be it from smokestacks, or be it from the port in Oakland, that particulate matter gets in the air, and those little people are more susceptible to it because the concentrations increase the closer that you get to the ground. Now, this is not incontrovertible. This happens if there's more wind. In different environments, it may change. But this is data from a 2018 paper that came from China, and complicated slide. But the message of this slide is that this particular matter, be it PM1, PM2.5, or PM10, is all at higher concentrations the closer you get to the ground. And if you look at these, the height that they have here is actually in meters, and you can see that it is, when you get to be like 0.5 meters closer to the ground, that's kind of where we see a lot of children breathing, and there's a lot more particulate matter, so that makes them much more susceptible to injury. Moreover, the immune system is quite different as you mature. And I'm not making any argument that I know exactly what's happening in the immune system in the lung, but I think the overarching thought is that the immune system kids are more vulnerable. There's more immune activation that can happen. They're more susceptible to infection. Whether or not they have as good innate immunity as older people is not entirely clear. This is a slide from a paper from 2015 where they kind of looked at the immune system over the lifespan, arguing that after the dissipation of maternal antibodies, there's considerable vulnerability for children. And so I would argue very strongly that children are unique, that they represent sort of the canary in the coal mine. For those of you who don't know, the person that really first suggested that there'd be a canary in the coal mine was Sir John Haldane. Sir John Haldane is perhaps the father of modern gases, so to speak. He's the person that really thought about how oxygen could be used, and that oxygen as a supplement can heal and help people. And we all know about all of us physiologists and physicians know about the Haldane effect. So a very famous physiologist. And he noted that we should put species that was more sensitive out into the field so that we could see early warning signs of damage or of danger. And hence canaries would go into the coal mines, and they were very susceptible to carbon monoxide related injury. And if the canaries were having a problem, the humans needed to get out fast. And I would argue that children are indeed the canaries in the coal mine. And today we'll spend some time talking about, first, climate change and children's respiratory health. We have some wonderful speakers that are going to address that. We're then going to talk a little bit more about the effect of climate change on the environment rather specifically. And we also have very wonderful speakers to address that. We are going to speak a bit about equity and respiratory health. And again, we have a panel of speakers that are going to be able to address that. And then finally, we're going to talk a little bit about what might be some putative solutions. And then together, hopefully, we're going to consider how we might have a call to action to not just hear about this, but to try and engage in a way that's meaningful. I know that for myself and for all the colleagues that I speak about, we know this is important, but we don't know what to do about it. And there's a feeling of helplessness, and we need to retake our autonomy and try to figure out ways of engaging. And in fact, the National Academy recently had a grand challenge with 4 strategic objectives, which I think are consistent with what we're going to try and do today. We're going to communicate the climate crisis as public health. They hope to think about a roadmap for systems transformation. They want to catalyze the health sector to reduce its climate footprint. For those of us who work in a hospital, we recognize that our climate footprint every day is rather large, and we want to accelerate research and innovation. So with your help today, hopefully we'll accomplish some of these goals, but in point of fact, I don't think it's realistic to even think that we'll accomplish anything, but maybe we'll begin to take one step forward. So with that, I'm going to turn over to my colleague, Dr. Morales, who will have the pleasure of introducing our first speaker. I can get the